of the secretary, on behalf of the secretary, Dr. Sampath Kumari, I'm really pleased to invite all of you for Revati Madam to kindly start the program with an inauguration and the welcome address.
Yeah. Good evening, all. It is indeed a great pleasure to welcome you all to this first Bodhana program of this year. And I welcome both the SRM professors, Anuradha and Kartika, and externals, Dr. Padma and Chitra, and also both the students. And the obstetric topic in the last class, we are having fibroid today. And I am sure all the students who have joined will definitely be benefited. I welcome all the students also. Now over to the Kalpana or
Shall I will just introduce, Madam, can I introduce the others for the entire, thank you so much.
Examiners.
Thank you. Yeah, thank you, Revati Madam, for the welcome address. I would like to welcome today's coordinator, Dr. Sampath Kumari Madam is not there. We have with us Dr. Can I have the next slide, Dr. Kalpana? Previous slide, Dr. Kalpana Madam is Secretary of the Madurai OBGYN Society, a very, very active member in TNFOG. I invite you and welcome you, Kalpana Madam, to shoulder the entire evening's program. I mean, to take up the responsibility of Sampath Madam also. So you will be there. Thank you so much for offering to be there for today evening. And next, I would like to request Kalpana Madam to introduce both the internal examiners as well as the external examiners. The two postgraduate students are Dr. Shruti and Dr. Dharani. Both of them are students of SRM. Madam Kalpana ma'am, would you like to introduce the examiners, please?
Yes, thank you, Vijayalakshmi ma'am. This wonderful PG training program had been started by our TNFOG President Anjalakshmi Madam and Secretary Sampath Kumari Madam. Now this program is continuing in the next tenure also with the blessings of President Revati Janakiraman Madam and Sampath Kumari Madam. We have learned experts and experienced teachers. It's my pleasure to welcome Anuradha Madam, who is a Professor HOD SRM Medical College and Research Center. Madam had got teaching experience of almost 20 years, various publications in international journals, and she has been an examiner for both undergraduate and postgraduates. Welcome, ma'am. Our next examiner is Kartika Prabhu, ma'am, who is a professor, SRM Medical College and Research Center. Madam's special interest is high-risk pregnancy and gynec endoscopy. Madam has received various awards, received gold medal during her MD and Asha Bakshi Award. Also, she has received gold medal for a research paper in 2020 and also A.L. Mudaliar Traveling Fellowship Award. 20 publications to her credit. Faculty in various national, international conference. Welcome, ma'am. Our next examiner is from our own society, Case Chitra Madam, who is a dynamic member of easy member of Madurai OBS Gyne Society and now Professor HOD Velamal Medical College Research Institute. She was director of social obstetrics, ISO KGH hospital, and she has got a teaching experience of almost 20 years. She is a member of editorial board, EC and EC member of most received including Best Doctor Award and various publications to her credit. Welcome, ma'am. Our next examiner is Padma ma'am, who is also from our own society, dynamic EC member and past treasurer of Madurai. She has done fellowship in gynec oncology. So she was past secretary of Vijayawada OG Society, now and HOD in Meenakshi Mission Hospital. hysteroscopic and robotic surgeon, and also gynec-oncologist. Madam's interest is in medicine, and she was a past president of IMA Madurai Meenakshi branch, past joint secretary of AGOI, and organizing secretary of various conferences. And she has given guest lecture in various conferences. Welcome, ma'am. Invite the presenter, who is Dr. Shruti Ramesh, who is doing final year MS in Madurai Medical College. Do we have co-presenter? Yeah, I also welcome Dharani, Dr. Dharani, yes, who is also a final year MS candidate, who are going to present about fibroid. Over to you, presenters.
Yes.
Start presenting. Start presenting. Start presenting.
Good evening, ma'am. I'm Dr. Shruti Ramesh, final year from SRM Medical College Hospital, ma'am.
Yes, go on.
Ma'am, 1 second.
Any difficulty in sharing the slides?
1 second, ma'am. Over, ma'am. Coming.
What is the problem, Shruti?
Ma'am, that slide sharing, 1 second, ma'am.
Initially it started, no?
Yes,
It was. What happened, Shruti?
Ma'am, coming, ma'am. Ma'am, is it sharing, ma'am?
Yeah.
Yeah.
Mrs. X, a 45-year-old multi-Paris woman residing in Gudwanjali, studied up to high school, a homemaker by occupation, belonging to upper middle class according to modified Kupuswamy classification, was admitted with the chief complaints of heavy menstrual bleeding for 1 year, and the last menstrual period was 7th January 2022. History of presenting illness, heavy menstrual bleeding for 1 year. Patient was bleeding for 5 to 7 days in a for 30 days. Cycle was prolonged when compared to previous cycles. Changes 5 to 6 pads per day, which is fully soaked, associated with passage of clots and pain. Bleeding not controlled with medical management for the past few months. Pain is present during menstruation, which is of dull aching of type intermittent, not radiating, relieved with medications. She gives no history of intermenstrual bleeding, no history of postcoital bleeding, no history of irregular cycles in the past, no history of palpitation, dyspnea, EC fatigability, no history of mass palpable per abdomen, no history of hormonal drug intake, no history of difficulty in micturition, no history of difficulty in passage of stools, no history of swelling of feet, no history of loss of weight or loss of appetite. Menstrual history, patient attained menarche at the age of 12 years. Previous cycles were regular, which was lasting for 3 to 4 days for 30 days. Normal flow, which is not associated with passage of clots or dysmenorrhea. Last menstrual period was January 7, 2022. Marital history was patient was married since 22 years, a non-consanguineous marriage. Obstetric history, para 2, life 3, previous to LSS, was not sterilized. Last childbirth is 17 years ago. She gives no history of contraception usage. Personal diet, mixed diet, sleep, bowel and bladder normal, sleep pattern normal. Past medical history or surgical history, history of sinusitis, which is medically managed. History of migraine, was on medication 1 year back, now not on any medication. History of anemia correction in July 2022 with 2 doses of injection iron was given. No history of blood transfusion or hospitalization in the past. Not a known case of diabetes mellitus, hypertension, asthma, epilepsy, tuberculosis, or thyroid disorders. In family history, she gives no history of endometrial or ovarian or breast or GIT malignancies. Summary, a 45-year-old multi-Paris woman came with chief complaints of heavy menstrual bleeding, associated with passage of clots and pain during menstruation since 1 year. Changes 5 to 6 pads per day, which is fully soaked. Gives history of anemia correction with injection iron sucrose 2 doses in July 2022. She is a known case of migraine, now not on any medication, and known case of sinusitis, which is medically managed. General examination. Patient is moderately built.
Srushti, just a minute.
Yes,
Can you
ma'am.
just describe the menstrual bleeding pattern as by the latest FIGO guidelines? Her menstrual history alone. What are the things you will focus on?
Ma'am, we'll focus on the duration of the cycle, ma'am, like whether it's regular. So the normal duration is between 24 to 30 days, ma'am. And she is having around.
See, that's not duration, right? It's the frequency.
Frequency. Yes.
Frequent cycles. I'm sorry, frequent cycles. Then whether you can say prolonged, if it's more than 8 days, so she's bleeding for more than 8 days, it's called as prolonged cycles, prolonged duration of bleeding, ma'am.
Okay, so frequency, next duration, then
Duration, ma'am. And then if she's then more than 80 ml of blood is if she's having, it's called heavy bleeding, ma'am. More than 80 ml of bleeding in a cycle.
so that you call it as flow volume, isn't it?
No volume, yes, ma'am.
Flow volume, but then you can't measure. So
Yes,
we
ma'am.
just have to go by the patient's version.
Yes,
And she
ma'am.
will always say it in comparison with her previous menstrual cycle. And we
Yes.
have to correlate with the present hemoglobin, whether her history is right or wrong, isn't it?
Yes, ma'am.
So
Yes, ma'am.
flow volume, how will you report it as heavy, normal, or light?
Ma'am.
That's how the figure goes.
Ma'am.
That's what the figure says, isn't it?
Yes, ma'am.
The latest guidelines,
Yes,
FIGO
ma'am.
guidelines for the menstrual pattern. So you
Yes,
ask for the frequency, duration, the regularity, and the flow volume.
No volume. Yes, ma'am.
Okay, and then what are the other things you need to inquire?
Ma'am, then you have to inquire like how many pads she's changing per day, ma'am, whether it is fully soaked or
No,
partially
I'm
soaked.
not asking the thing. Well, the other two things. You have asked for frequency, duration, regularity, and flow volume. And what are the other two things as per the FIGO guidelines you have to ask?
Intermenstrual bleeding
Yeah,
and postcoital bleeding, ma'am.
intermenstrual bleeding. Yeah, or instead of postcoital bleeding, any unscheduled bleeding.
Unscheduled bleeding. Okay.
Okay. Yeah, carry on.
On general examination, patient is moderately built and nourished. Afebrile, pallor is present, no pedal edema, no ictus, no clubbing of sinuses, no lymphadenopathy. Bilateral breast examination was normal, thyroid is normal. Vitals, pulse rate is 82 beats per minute, which is regular in rhythm and rate, normal volume in both the arms. Blood pressure is 130 by 80 millimeters of mercury in right arm in sitting posture. BMI is 30.30 kg per meter square. On systemic examination, cardiovascular system S1, S2 heard, no murmur is present. On respiratory system, bilateral air entry was there. Normal vesicular breath sounds were heard, no added sounds. Central nervous system, no focal neurological deficit. On abdominal examination, a patient was obese, suprapubic transverse scar present 2 centimeters above the pubic symphysis. No engorged veins or sinuses. Amicus is flat. Hernial orifices were free. On palpation, a midline mass corresponding to 18 to 20 weeks of gravid uterus size, which was irregular and lower border was not palpable. Firm in consistency, occupying the hypogastric region and the umbilical region. Non-tender, side-to-side mobility was present, and no organomegaly. On percussion, no ascites, and dull note was heard over the mass. Sorry, ma'am. On local examination, mons pubis and pubic hair were normal for age. Labia majora and minora appears normal for age. On perspiculum examination, cervix was high up. Cervix appears healthy. No bleeding or discharge was present. On bimanual examination, uterus is irregularly enlarged to 18 to 20 week size of gravid uterus size, which was firm in consistency and non-tender. Posterior fornixes were full. Other fornices were free. Transmitted mobility was present. Groove sign is absent. So overall summary, a 45-year-old multiparous woman came with complaints of heavy menstrual bleeding for 1 year, associated with passage of clots and dysmenorrhea. On general examination, pallor is present. Abdominal examination revealed an irregular midline mass corresponding to 18 to 20 weeks of gravid uterus, which is firm in consistency. non-tender with side-to-side mobility. Bimanual examination confirmed it as a uterine mass corresponding to 18 to 20 weeks gravid uterus size. Differential diagnosis is abnormal uterine bleeding, may be due to uterine leiomyoma, adenomyosis, malignancy. Probable diagnosis is abnormal uterine bleeding due to leiomyoma, uterine leiomyoma.
Okay. Why do you say it is due to leiomyoma? What malignancy will is your other differential diagnosis? Malignancy is a very broad term.
Yes, ma'am.
Yeah.
Ma'am, on palpation, we could feel a mass of 18 to 20 weeks of size, ma'am.
Yes. So mass abdomen with she has got heavy menstrual bleeding, right?
Yes. Yes,
That is her main complaint.
yes, ma'am.
What is the other main differential diagnosis you would like to associate with? Mass abdomen with or without?
Ma'am, I didn't understand. Ma'am.
No, first
Madam is
diagnosis is, yeah.
Yeah.
First diagnosis is uterine, fibroid
Yes,
uterus. What is the other
Adenomyosis.
differential diagnosis with mass abdomen? Adenomyosis, will it be palpable? Will it be reach this much of size? 18 to 20 weeks? What will be the size in adenomyosis?
Around 12 weeks to 14 weeks.
Yes, 12 to 14 weeks, right?
Yes.
So there's a mass abdomen.
Yes,
What is the other differential diagnosis? Commonly associated or commonly occurring condition.
correct.
What is her age?
Ma'am, 45-year-old, ma'am.
45. Okay.
Or any ovarian
Yes, ovarian.
mass, ma'am.
Ovarian tumor.
Ovarian
Okay.
tumor.
Right. Now, how do you differentiate between fibroid uterus from an ovarian tumor? I say it is a case of ovarian tumor that also
Ma'am,
presents with a mass abdomen.
okay, ma'am. On usually on history wise, they give usually the ovarian malignancy, they won't have complaints of heavy menstrual bleeding, ma'am. And then they
Not
give
necessary, ma'am.
Not necessarily.
Not necessary.
Which ovarian tumor will be associated with the heavy menstrual bleeding?
Heavy menstrual
Normal bleeding.
hormone estrogen secreting tumors, ma'am.
Which tumor?
Granulosa cell tumor and
Theca cell tumor, ma'am.
Granulosa cell tumor. Okay. Non-hormonal secreting tumors also can produce
Ma'am,
menstrual
when there is
symptoms.
both, when there's both associated with both endometrial and ovarian malignancy, that time they'll have endometrial bleeding.
No need, not needed. Need not be associated. Ovarian malignancy alone, non-hormone secreting tumors also will produce menstrual bleeding. Okay.
Then on per abdominal examination, ma'am, if it's an ovarian mass, you can feel all borders can be felt, ma'am. Whereas in a ovarian, in a uterine pathology, usually the lower border will not be felt, ma'am. And now when you see the mobility, it will be side-to-side mobility in a uterine mass. Whereas in ovarian mass, you can all the side mobility can be there, ma'am. Mobility is there present all the sides, and then
Exception. What is the
ma'am, if it's a
exception?
malignancy, it can be fixed, ma'am. In a malignant tumor, the mobility will be fixed.
Okay, proceed.
Okay.
Then on per vaginal examination, ma'am, you can feel that there's a groove sign, ma'am. So on palpation, you can feel that there's a mass, like a separate groove is formed between your examination. That time, if there's a groove sign is positive, then it's an ovarian pathology. If the groove sign is absent, then it is a uterine pathology, ma'am. But in
Is it always Masushri?
No, ma'am. Sometimes when there's a broad ligament fibroid, ma'am, the groove sign can be positive in a broad ligament fibroid, ma'am, because they'll have a stalk and it behaves sometimes like an ovarian mass, ma'am. So you can sometimes that is not 100% confirmed, ma'am. And there'll be transmitted mobility will be there, ma'am, in uterine pathology, whereas it will not be seen in a ovarian pathology, ma'am.
Okay. So you have come to the diagnosis of uterine leiomyomata.
Yes, ma'am.
What are the other signs and symptoms she can have? One is heavy menstrual bleeding. How can
Yes,
she present with other symptoms? What
Ma'am,
are
she
the
can
other
have-
symptoms?
Other than that, she can have dysmenorrhea, ma'am.
What type of dysmenorrhea?
Ma'am, usually they have spasmodic or they can also have congestive type of dysmenorrhea also, ma'am.
Congestive type of dysmenorrhea will be present in which type of fibroids? FIGO, as per FIGO. And spasmodic will be present in which type of fibroids?
Spasmodic is more of intramural, will have spasmodic type of.
Which one? Which one? Spasmodic in which type?
Intramural fibers.
Intramural spasmodic.
Submucous will have congestive type.
Intramural will have which type of dysmenorrhea?
Congestive type of.
Yeah, congestive. Spasmodic in?
Submucous.
FIGO? Classification?
Ma'am, type 0.
Type 0. Okay.
Then they might have some pressure symptoms, ma'am, like urinary symptoms. They might have increased frequency. If it's an anterior wall fibroid, ma'am, it will be pressing on the bladder, which will lead to increase in frequency. Sometimes it's a posterior wall fibroid, which is a huge posterior wall fibroid. In the POD, it can lead to urinary retention can be there, ma'am. And if it's a lateral fibroid or any lateral fibroid, they can, or broad ligament fibroid, there might be compression of the ureters, ma'am, which can lead to hydroureteronephrosis also. Sometimes if it's a posterior wall, there can be compression features on the rectum, which can lead to constipation also, ma'am. These are the other symptoms they can come with, ma'am, pressure symptoms.
Young women?
Infertility, subfertility, ma'am. They'll come with complaints of subfertility.
Okay. How does fibroid cause infertility or subfertility?
Ma'am, there can be a distortion of the endometrial cavity will be there, ma'am, which will lead to implantation failure. And there'll be decreased blood supply to the implanted embryo, so that will lead to failure, ma'am. Then sometimes if it's a large cervical fibroid, it will there'll be an anatomical distortion which doesn't allow the sperm to ascend into the uterine cavity, ma'am. And if a fibroid is present in the cornwall, this one it will lead to a uterine block. I mean, a tubal block which does not allow the process to happen, does not allow the entry into the uterus. Then there'll be an alteration in
Srishti, you said a cervical fibroid will not let the sperm go in. But then now and then we do see patients with cervical fibroid presenting with pregnancy, and then sometimes they come with abortion, no?
Ma'am, a large fibroid, ma'am, where the cervix is pushed to one side or pulled up to one side, ma'am.
Okay. Now that you have told that, suppose a patient with a cervical fibroid, she comes to you with incomplete abortion. So what precautions will you take? What problems do you anticipate in evacuating the products?
There can be difficulty in instrumental evacuation, ma'am. There can be excess bleeding, dilatation.
So what should you do? So what do you have to do in those kind of situations?
Ma'am, it is better to do it under anesthesia.
Yeah, definitely under anesthesia.
Under which guidance?
Adequate blood has to be.
No, any guidance, under any guidance you want to do the evacuation?
Ultrasound.
Yes, it's better always to do it under ultrasound guidance. Otherwise, what will happen? Otherwise, what can happen, ma? You can go into a wrong track and perforate the uterus or the cervix, the other side, the side opposite to the fibroid. Can get damaged, or you may not even get into the cavity at all for that. Okay. And same thing can hold good for this patient also. When you're trying to do a DNC to evaluate her endometrium and try to get an endometrial sampling, the same thing can happen, isn't it?
Yes,
if she's having a cervical fibroid.
Yes, ma'am.
So suppose for this a patient who has come to you at 45 years,
yes,
what will you do to get an endometrial sampling?
Ma'am, you can
she has a cervical fibroid. She's
Yes.
bleeding. And the ultrasound says there's a very thick endometrium. Endometrial thickness also is more. So how will you sample?
Under guidance, we have to do the hysteroscopy.
Is there anything else you can do?
And hysteroscopic guided endometrial biopsy.
Hysteroscopic guidance, okay. If you don't have all these things, anything you can do in the OPD?
Pupil biopsy office.
Yeah, pupil is a soft catheter. It can go.
Yes.
When you gently introduce it, it will take the path because it's a very thin one, no?
Yes.
You can negotiate. Most of the times it will be in a position to negotiate. So any soft catheters you can use for sampling. Same way when you want to do a DNC or evacuate the products also, once again you can use soft catheters and ultrasound guidance and then evacuate the products.
Okay.
Okay. Yeah, and this patient you said in the clinical examination, can you go to the clinical examination slide? Yeah, so you said no.
Yes.
Yeah, here. So the other finding, what is there? Apart from the groove sign, you said the cervix is pulled up, no, somewhere. Posterior fornix fullness is there. Irregular. No, the previous one. Yeah, perspeculum examination. No. The cervix is high up. Why do you think it is high up?
Ma'am, maybe because one, either if it's a large fibroid, also the cervix can get pulled up, ma'am. Or she gives a history. It's a previous to LSCS also. She gives a history, ma'am. So because of that also it can be pulled up.
So in what way is this finding important in your clinical management?
Ma'am, we can anticipate in clinical management, like if you're planning for a surgery or if we can anticipate adhesions.
Yeah, that is one thing. So once again, this patient may not have a cervical fibroid, but then because the cervix is pulled up, what will happen when you try to sample the endometrium or when you try to put any instrumentation into the uterus? Once again, we have to do under ultrasound guidance or we have to take adequate precautions. Otherwise, we'll not be in a position to either get a sample or the procedure done, isn't it?
Yes, ma'am.
So that is the precaution you have to take. So all the clinical findings which you are, enlisted here is very, very important for every patient who has a large fibroid and you want to manage them clinically. Okay.
Yes.
Yeah. So now what will be a next step?
Ma'am, for next we have to do a basic investigation like hemoglobin and all have to be done to rule out anemia, ma'am. And then we have to do an ultrasound to confirm the diagnosis of our this case, ma'am, of the patient, confirm the diagnosis. In ultrasound, we have to check how many, we have to map the fibroid, ma'am, how many numbers are there, where is the site of the fibroid, size of the fibroid, and then the endometrium, whether to see the endometrium and to see the pelvic, any other pelvic pathology is present, and to rule out any hydroureteral nephrosis is there or not, ma'am, to see the kidney as a whole, to see the kidney as a picture, ma'am. And then we have to go ahead, ma'am.
No, so you have to ask not only of the pelvis, but of the abdomen also.
Abdomen, ma'am. Abdomen with pelvis ultrasound has to be done, ma'am.
Okay. So how will you differentiate? Yeah, ma'am, go ahead.
Yeah. What will you do next? You have done an ultrasound, endometrial thickness you have evaluated. She has got heavy menstrual bleeding. What will you do next?
Ma'am, I'll do a hemoglobin because she looks pale. So I'll look for anemia. And if there's anemia, we have to correct the anemia and symptomatic management. Because medical management with analgesics, NSAIDs and fibrinolytics will be given, ma'am. And since she's 45-year-old, I'd like to take an endometrial biopsy also for this patient. So preferably I'll go for hysteroscopic guided biopsy.
Okay. And, why do you do an endometrial biopsy here?
Because malignant, to rule out any endometrial pathology, ma'am. Like
what endometrial pathology?
Endometrial hyperplasia and endometrial carcinoma, because 3% of fibroid cases are associated with endometrial carcinoma.
Endometrial cancers. Okay. Hyperplasia and okay. What may you ask? You wanted to ask something. Yeah.
What is the other DD you will try to rule out in an ultrasound?
Associated adenomyosis, ma'am.
Any endometrial polyp.
Okay. So how will you differentiate a fibroid from an adenomyosis in ultrasound?
Ma'am, and whereas this one ultrasound, the fibroid will be a regular hypoechoic mass, ma'am. You can see it as a hypoechoic, well circumscribed mass. Whereas adenomyosis, it is an irregular, the junction will be distorted, ma'am. The endometrial myometrial junction won't be clear.
And asymmetrical thickening of the anterior and the posterior uterine wall will be there, ma'am. Myometrial cyst can be present. Myometrial lacunae can be there, ma'am. Loss of
fan-shaped shadow can be present in the adenomyosis, ma'am. And then there can be irregular junctional zone, or the regular junctional zone can be present. And
all these are features of
adenomyosis.
Okay. And what about a fibroid?
Ma'am, it will be a hypoechoic, discrete over a round mass, ma'am.
Sometimes it can be hyperechoic also, ma'am. Hypoechoic or hyperechoic. Sometimes it's a calcified, it be hyperechoic, ma'am. Sometimes, or if there's any degenerative changes, it will be different appearance, ma'am.
Okay. And any clue from adding on a color Doppler or something?
Yeah, ma'am. Vascular ring will be seen.
Peripheral vascular ring will be there, ma'am.
Where? In which?
In fibroid, ma'am.
In a
Whereas in
fibroid.
adenomyosis, there'll be a translesional vascularity will be there, ma'am.
Yeah. So that's very important. So that is the reason why in a fibroid, we go below the capsule and enucleate it.
Yes,
when you go in the right plane, it won't have much bleeding. And the junction, whereas in an adenomyosis, even, I mean, we have to cut the tissue, isn't it? It doesn't have a pseudocapsule.
Yes.
Whereas a fibroid has a pseudocapsule, and the pseudocapsule is the place where you have your vascularity.
Yes.
Then what are the other things you will look for when there is a large fibroid?
Ma'am, I look for hydroureteronephrosis because a large fibroid.
That you already mentioned. I'm saying in the fibroid per se.
Any distortion of the endometrial cavity, you check, ma'am.
Okay. So that is how the FIGO classification goes, isn't it?
Yes, ma'am.
Okay. So which part? I mean, can you just say the FIGO classification for fibroid or it is SG classification, isn't it? ESG. So what does it say? How does it classify fibroids based on the location?
The E is the one FIGO classification that is type 0, that is completely in the cavity, ma'am. Submucosal pediculi in the cavity. Then type 1 is less than, it is submucosal less than 50% in the myometrium. Type 2 is it is submucosal more than 50% in the myometrium. Type 3, it is completely in the myometrium but contacting the endometrium. Type 4, now type 3 is also considered submucosal, ma'am, because it is having a contact with the endometrium. Type 4 is 100% intramural fibroid. Type 5 is more than 50% intramural, subserosal, but more than 50% is intramural. Type 6 is subserosal, less than 50% intramural. 7 is pedunculated subserosal fibroid, ma'am. 8 is other parasitic fibroids, ma'am.
But why is this important? Why should you do a ultrasound to check for the location? What do you call this as?
Mapping
See,
of the
this patient, okay, 45, we may be doing a hysterectomy. For a younger patient, why is it important?
Ma'am, depending
on the site, location?
Ma'am, depending on the site, the mode of treatment can differ, ma'am. If it's a submucosal, we can do the hysteroscopic resection can be possible, ma'am. If it is subserosal, even the laparoscopic, if it's intramural or subserosal, laparoscopic myomectomy can also be tried for a patient who wants to retain a fertility or to retain a uterus, ma'am. So the mapping will help us to determine the management required, ma'am.
Good. So this finding out the fibroids, the location of the fibroids, and we should request our sonologist, our radiologist to give a picture, rough picture of when you are doing a ultrasound to place the different fibroids where they are.
Yes.
So why is it important? When you do hysterectomy, it is not, very important. But when we are doing a myomectomy, this localization of fibroids is very important. For what reason?
Ma'am, so that we should not.
As you said, depending on the mode of approach, either hysteroscopic or laparoscopic. Then what else?
Ma'am, if it's an, like, we have to be careful not to enter into the endometrial cavity while removing the myoma, ma'am. We should be careful.
Always help it, right? Sometimes you will have to enter. It
Yes,
will get opened up. Okay,
Yes.
that is one thing. Then next.
Ma'am, if submucosal, we can go ahead for hysteroscopic dissection can be done, ma'am. Submucosal.
No, that you already said, na? The route.
Yes, ma'am.
So you need to plan
what if
your incision sites.
Yes, ma'am.
How many incisions you are going to make?
Yes,
And with one incision, how many fibroids you can
be taken out? We have to minimal
or remove.
Very minimal incision
Okay.
to be used. Preferably
What do you call that? What do you call that? Making an incision and trying to get as many fibroids through that single incision.
What do you call that?
What do you call that? It is going inside.
Going inside. What do you call that? Tunneling. Tunneling. Okay. Where will you make the incision? One incision you have to make. Where will you make the incision?
Anterior.
Anterior?
Near the anterior one, ma'am. It should not be close to the cornal region. You have to
Cornwall.
Not near the corner, ma'am. Not near the corner.
Anterior as low as possible. Okay. Multiple fibroids, you'll do a tunneling incision. If it is a large posterior fundal fibroid,
ma'am, to prevent, ma'am, posterior wall, like we can give a posterior wall incision, ma'am, like, but to prevent.
No, you want to prevent posterior wall incision. Anything you can do.
No, she said you can do posterior wall. Huh? Yeah. Why do you not prefer posterior wall incisions?
Ma'am, additions will be more, ma'am. Additions to sigmoid colon and all will be more post surgery.
Okay. How can you prevent adhesions? Anything you can use?
Ma'am, surgery seal and interseed can be placed to prevent adhesions, ma'am.
Okay,
and there's one more surgical technique called Boney's hood surgery.
Yeah, that's what I wanted you to answer first. Large posterior fundal fibroid. What surgery you do? Boney's
hood surgery, ma'am.
Boney's
you take the
operation.
flap and the flap will be overlapped in the anterior wall and it will be sutured.
You close the anterior wall with the hood, which is in the fundus. Okay.
Fundus.
Right. Okay. What complication you expect during myomectomy?
Ma'am, excess bleeding will be there, ma'am.
Excess bleeding. Now, how are you going to control that bleeding?
Ma'am, we can use vasopressin, ma'am. Nowadays, we're using vasopressin 20 units. We're using, ma'am. And then this is during surgery, ma'am. Prior surgery, to reduce the size and to control the bleeding, we can use treat medications, ma'am. Then during surgery,
what medications? Prior to surgery, there are some medications you use. During the surgery, how will you? Vasopressin.
Vasopressin 20 units.
How will you give that?
Ma'am, it's surrounding the capsule. Around the capsule, you have to inject it, ma'am. It should be diluted with 200 ml NS, ma'am. And it should be injected. And we have to.
How much will you inject?
10 ml.
Oh, the whole 200 ml?
No, ma'am. Ma'am, until we see the blanching over the fibroid, ma'am.
Half that. That is 10 units. You inject 10 units subserosal, in the subserosal plane. It is where you have the vascularity. Okay. So you got two methods. One is the large volume dose and the other one is small volume. Either your dilution can be less. 20 units in 60 ml or 20 units in 200 ml. Okay. Okay. What complications you can expect when you are using vasopressin?
Pulse rate can become.
What does it do? How does it produce, reduce the bleeding?
Vasoconstriction.
Hmm.
Due to vasoconstriction, produce the bleeding, ma'am.
Hmm.
So
So what can happen?
Reflex.
See, when you give a large volume, injection, just like our Machitra madam said, 20
Yes,
units in 200 ml, what happens is the vasopressin part of it causes vasospasm or vasoconstriction. Then the saline part of it, it fills up the vascular channels in the fibroid and the uterus. Okay, so even when you make a nick on the uterus, instead of blood, what oozes out is only the saline.
Yes, ma'am.
Okay.
Yes,
So that is the two ways it reduces the blood loss.
okay.
Okay, then what drugs do you give pre-operative to reduce the vascularity? And in what situations you give it?
Ma'am, basically the newer drugs they're saying that ulipristal acetate is initially they used to give GnRH analogs, ma'am. So now they're saying that ulipristal acetate is better than GnRH analogs because when you give GnRH analogs, the small fibroids, it will be reduced, ma'am. So recurrence will be higher if you do a myomectomy. During surgeries, the fibroids will not be seen, ma'am. The plane won't be accurate if you're giving GnRH analogs, so that can be missed out. So, but in ulipristal, and the volume will be more, the fibroid volume will be much less, much more reduced in ulipristal acetate, ma'am.
When you say that, then how does it help the, recognizing that small fibroids? If it causes more shrinkage of fibroid, that's what you said, no? Then even the small fibroids will get missed even when you give ulipristal.
Yeah, ma'am, ma'am, it's only to postpone the surgery for a few months. You can give for medical management, ma'am.
So that is not the difference between GnRH and ulipristal. Why now people give less of GnRHs? One, it is difficult to get the tissue planes.
Yes,
whereas that problem is not there with ulipristal.
Yes,
Then second thing being, when you give GnRH analog, people tend to have hot flushes.
Yes, ma'am.
Young ladies especially, they have hot flushes. Yeah. Whereas that is not seen with ulipristal. Then you may have to give add-on therapy when the patient is finding it difficult with GnRH. Okay, so that is the reason why people nowadays slowly are switching on to ulipristal. But what is the problem when you use ulipristal?
Ma'am, liver, it can affect the liver, ma'am. So it can lead to even liver failures also if you are using without monitoring the liver function tests, ma'am.
So LFT monitoring needs to be done.
Done, ma'am.
Yeah. Okay, then what group of fibroids you prefer to give GnRH or ulipristal prior to the procedure? Intramural, okay, not much, but when a patient is having heavy bleed and you want to correct anemia, then that is one situation. What other situation? Specifically, in which location you like to give GnRH?
Submucous.
Why?
More bleeding will be associated with submucous fibroids.
Is it only for the bleeding or for something else also?
Infertility can be, ma'am.
Pardon?
Infertility, like people are having subfertility or associated.
That is the reason why do you want to excise a submucous fibroid per se.
Yes,
but is there a reason why you want to give GnRH analog in a submucosal fibroid? How do you approach a submucosal fibroid? Hysteroscopy, isn't it? So when you are doing a hysteroscopy, what is important when you want to do a fibroid resection? Which is the deciding factor?
The size of the fibroid.
Yeah, why is the size important?
Ma'am, because the number of sitting, like if it's bigger the size, the sitting will be more, like more number of time it has to be resected, ma'am. It won't, and complete resection is difficult if it's a large fibroid, ma'am.
So what is the optimum best size for doing a hysteroscopic myomectomy?
4 to
beyond
10.
Which you want to give GnRH?
More than 10 centimeters.
Huh?
No. 10. So big.
It's so big.
Less than 5
No,
centimeters.
no. Yeah.
5 centimeters.
Even 5 is big. Ideally, it will be around 2.5 to 3. That makes it easier. You can do it in one sitting, but anything more than that becomes difficult and you have to reduce the volume. See, because in hysteroscopy, what is important is the volume of the fibroid. When it is a 1 centimeter fibroid, then volume is always cube, isn't it? 1 into 1 into 1 is 1. So it doesn't make a difference. But if it is 2 centimeter, it is 8. And when it becomes 3 centimeter, even for one single centimeter increase, what happens is 3 into 3 into 3, what happens? It is 27. So just between 2 centimeter and a 3 centimeter fibroid, see the volume difference. From 8, it becomes 27 because it's a cube. Volume is always measured in cube. So that is the reason you want to keep this fibroid size always smaller. And when you want to resect large fibroids hysteroscopically, what happens? The complication rate also goes up, right?
Yes.
So what are the complications you foresee with a hysteroscopic myomectomy?
They can be sometimes there can be perforation as a possibility. Then there can be fluid overload syndrome is there, ma'am, and they can be used more than 1,500 ml. There can be fluid overload syndrome. So hyponatremia, hypoosmolality, hypervolemia, and it can lead to pulmonary edema and cerebral edema, ma'am.
See, what fluid do you use, ma, during hysteroscopy for myomectomy? What are the different methods you know? Hysteroscopic myomectomy.
Ma'am, they can. No, they're saying that other alternatives like 5% dextrose and glycine and are better compared to
5% dextrose. So what are the different ways you can do a hysteroscopic myomectomy?
normal
One
saline.
by using a, wait. You can use a
Methods.
electrical
Methods.
resection using a resectoscope, isn't it?
Yes, ma'am.
The second one, you can use morcellators. Hysteroscopic morcellators you can use. Okay, morcellators is available only a very few centers. Most of the centers use only a resectoscope. So what are the two different resectoscopes you know of for hysteroscopic myomectomy?
Cold loop resector.
Cold loop illamma. What is the energy source you use? Monopolar or bipolar? So when you use a monopolar, what will be the fluid distension media you commonly use? The monopolar, you have to use a fluid which doesn't conduct the, or a non-electrolyte solution you need to use. Or so therefore you have to use a glycine or mannitol. Whereas when you use a bipolar, you have to use saline. You can use saline. So what is the advantage of using saline over this one, glycine?
Ma'am, sometimes glycine will lead to transient blindness.
You're telling the complication. What is the disadvantage, ma? How is glycine? Glycine is a
medium
hypoosmolar fluid, the slightly hypoosmolar. Okay.
Medium will be clearer.
Pardon?
Medium will be clearer with normal saline.
Say glycine is a slightly hypoosmolar fluid. Okay, and when that gets into the circulation, it causes disturbance in the osmolality, one thing. Then second thing is, when there is too much of glycine into the circulation, it causes hyperammonemia. Ammonium levels in the blood goes up.
Okay.
That is the two main disadvantage. So apart from having a fluid overload, there can be electrolyte disturbances. There can be hyperammonemia also.
Okay.
Whereas normal saline is a osmolar fluid compared to the human blood. Okay, so you can allow more amount of fluid intravasation. What is the fluid which can be allowed? Fluid deficit which is acceptable with glycine. So you don't have to do everything, but then at least for the exam sake, you need to know a few things. So what is the fluid deficit which can be allowed with glycine, and what is the fluid deficit which can be allowed with normal saline?
1,500.
When it is glycine, it should be less than 1,000. The fluid over, deficit should not become more than a liter.
Okay.
How do you calculate this fluid deficit? The fluid which has gone within the uterus and then what which has come out. The difference becomes the fluid deficit. So somebody should be in the theater to correctly see the fluid which goes into the cavity and the fluid which is coming out. And that volume becomes the fluid deficit. So with the glycine, you should not allow a deficit more than a liter. And when the deficit becomes 1 liter, you have to stop your procedure wherever you are. Okay. Whereas with the saline, the same deficit of around 1.5 to 2 liters is permitted. Understood, na?
Yes, ma'am.
Okay. So this is for the hysteroscopy. Then what about the laparoscopic part of it, laparoscopic or open surgery part of it? How do you do a myomectomy? Have you seen? No, you must have seen in the institute. Tell how do you do it?
The routes of myomectomy, we can do it via laparoscopy. Abdominal myomectomy can be done, or nowadays robotic is also come up. So, so basically, like once we enter, so before myomectomy, we have to plan the site of incision, ma'am. So for that, we'll do the mapping of the fibroids using the ultrasound. And then if there is a single fibroid, once we enter, we have to give vasopressin for vasoconstriction to reduce the amount of blood loss. And then we usually give a vertical incision over the fibroid. And then we reach the plane of cleavage, and by enucleation, we remove the fibroid, ma'am.
Why do you want to give a vertical incision?
Ma'am, the vessels or the fibroids, the uterus will be usually in the transverse. They're running the transverse plane, ma'am. So if you give a vertical incision, it is.
When do you give a vertical incision? In open or lap, or which position of the fibroid?
Usually open we give a vertical incision, ma'am.
Okay. Then tell what next?
Ma'am, then
Okay.
How do you?
Ma'am?
You enucleated the fibroid. What do you do next?
Ma'am, the dead space has to be obliterated correctly, ma'am. You should make sure that there should not be any hematoma, there should not be any collection between the dead space which we are obliterating, ma'am. And
how will you obliterate the dead space?
Intermittent sutures has to be taken and using vicryl sutures.
Using vicryl?
Layers, it has to be obliterated, ma'am. And then finally, the serosa has to be closed with the baseball sutures, ma'am. That will prevent the additions, prevent further future additions, ma'am.
Okay, now you're telling about abdominal myomectomy, open myomectomy.
Yes, ma'am.
Open myomectomy. Okay, what is laparoscopic myomectomy?
Ma'am, laparoscopic myomectomy, there are certain prerequisites are there, ma'am. The size usually prefer the size of the uterus should be less than 16 weeks at least, ma'am. Should not be a very big fibroid, ma'am. Then it is preferably if it's a subserosal or intramural, it's preferable, ma'am, to do a laparoscopic myomectomy. And then if it's a single fibroid, the size of the fibroid should be less than 10 centimeters.
Okay, then?
Ma'am, and then the disadvantage with laparoscopic is the dead space cannot be obliterated correctly, ma'am. So there can be a chance of uterine rupture will be higher in laparoscopic when compared to the open myomectomy, ma'am. And the procedure is prolonged, ma'am. So they can have more of anesthesia complications will be more in laparoscopic procedure. And there can be chance of the intramural hematoma can be more in laparoscopic procedures, ma'am. And when you're using the power source, there can be injury to the ureter also, ma'am, sometimes, if it's a very large fibroid.
No, multi-layer suturing cannot be done. I mean,
Yes,
it's not being done in laparoscopy.
Done in laparoscopic procedure, ma'am. So there can be higher chance of uterine rupture in the future, ma'am.
Future pregnancy.
Pregnancy, ma'am.
Okay. What is the other reason for uterine rupture with laparoscopic myomectomy? One is multi-layer suturing not done. The other one is?
One more is there's a possibility of intramural hematoma can be formed.
No. All that mean the same.
Ma'am, the
Anything
tissue lysis will be healing from secondary intention, ma'am.
No. What are you using to do the myomectomy? Use of energy sources. Too much of energy sources will cause tissue damage and healing. Yes. So as a result, the scar rupture is more with
weak, so there will be more
laparoscopic. Yes, myomectomy. Okay.
See, whatever, whether it is abdominal open or laparoscopy, you have to go by the principles of myomectomy. One, you use lesser, even in open surgery, people use monopolar current and all, not necessarily scissors. So limit your use of energy source. You can use scissor both or knife both in abdominal as well as in lap. You can use cut the myometrium with a scissor also. So limit your use of what is energy source. One. Then second thing is layered closure is the most important thing. The key for a proper closure or healing is the layered closure. So whereas in an open, when you can use interrupted sutures, in a laparoscopy, what suture do you use for a better closure? Have you heard of barb suturing?
Yes, ma'am. Yes, ma'am.
Barb suture. What is the advantage of barb suture?
Ma'am, the knotting is not necessary, ma'am. So every bite you take, it will be locked, ma'am.
Yeah, so it is fixed to the tissue. That is one thing, and there is no need to follow the suture material. Your assistant need not have to follow the suture material. That is one thing. And second advantage with these barb sutures is there is uniform distribution of the tension along the suture line. Okay, when you use interrupted sutures, the tissue is constricted at the level of the suture, and between sutures later on when there is post-op edema, there can be swelling. Isn't it? So the tension along the suture line is not uniform, whereas that is taken care of by the barb sutures. So even when you do an open myomectomy, we can preferably use barb sutures because of its continuous nature of the suture, there is a uniform tension along the entire suture line. Okay.
Okay.
How will you retrieve the myoma? You've done a myomectomy. How will you retrieve it?
By colpotomy, we can retrieve, ma'am, or by a mini laparotomy incision, we can retrieve it, or morcellation can be done, ma'am. So these are all the methods by which we can retrieve it.
Which is preferred and which is not preferred?
Colpotomy is preferred, ma'am, but now
nullifier colpotomy.
Then morcellators, now they're saying to avoid usage of morcellators, ma'am, because the tissue, if suppose sometimes a malignancy is being missed.
Even if you were morcellator, can you use something to prevent the spillage?
And the bag can be the bag can be used, ma'am, where you put the myoma inside it and
remove the closed. In-bag morcellation.
In-bag, yeah, in-bag morcellation. There are two types of morcellators, no? One is mechanical and power. Power morcellator. Which do you prefer? Which is not preferred?
Better.
Power morcellator better.
Usually that causes dissemination more. Okay. Younger woman, this chances of sarcoma, etc. will be less. Older woman, it is more postmenopausal, premenopausal around that time. Okay. When will you suspect sarcomatous degeneration?
Sudden women in a perimenopausal age group or postmenopausal age group with rapid growth of the fibroid.
What do you mean by rapid growth?
They grow almost 1 centimeter per.
So normally the fibroids are slow growing, ma'am.
Around 0.25 centimeters it grows per week, ma'am. Normally.
No. 0.2 centimeters per week is, yeah, that is rapid growth only.
No, 1 centimeter per year.
No. 1 centimeter. No. So if there is an increase in size of 6 weeks in less than a year, you call it as rapid growth. 6 weeks pregnancy size, right? You call it as rapid growth. What are the other features of sarcomatous degeneration?
Hemorrhage.
Yes, one is rapid growth, you said.
Hemorrhage and necrosis will be.
That is by histopathology.
They can present
Imaging
with
wise,
obstruct.
what are the other?
Spread to the.
No, others find symptoms the patient can have.
Symptoms like loss of appetite, weight loss.
Oh,
all
that's
that
not
can be
too
done.
late. See, what are the other things you look for in the imaging, ma? Any malignancy. What happens?
Vascularity will be.
Vascularity will be high. Then what else will be there? What kind of changes will be seen in the fibroid apart from the rapid increase in size?
What changes?
Irregular borders will become irregular.
No.
Blood supply, whether it will affect the growth.
See, when it is rapidly growing, what happens? And the blood supply is not catching up. What happens?
Necrosis.
So
the central necrosis
will be there, ma'am.
Okay, central necrosis. Okay.
So when all these findings are seen in the imaging, then what approach you should take? Do you go by a lab or you change your approach?
We change it to open, ma'am, abdomen.
Okay. And then what do you do when you suspect a sarcoma, when you open the abdomen? What should you do?
For a frozen section, ma'am.
Yeah. So when you have a frozen section, subject the specimen to a frozen section so that the patient surgery is over in one sitting only. Okay. So now coming to this case, she's 45 years, 18 to 20 week size uterus. What do you want to offer her? You did an endometrial biopsy and that just came out as proliferative endometrium, nothing more. So now what is your plan of management for her?
I would like to proceed for a hysterectomy, ma'am. So based on her age group and her symptoms, everything. So I would like to recommend a hysterectomy if the patient is willing to undergo a surgery, is willing for a surgical management.
No, this patient, she's willing to undergo surgery.
Hysterectomy is preferred, ma'am.
Hysterectomy is preferred. And you said she's a previous 2 C-section, isn't it?
Yes, ma'am.
Okay. So in this patient, what kind of incision would you like to give?
Midline vertical incision because 18 to 20 week size. Mass with history of previous 2 LSCA. So we suspect more additions also in this patient, ma'am.
Okay. So you like to go by a midline. Okay. Unfortunately, you made a transverse incision. You started the procedure with the transverse incision and you find that the uterus is too big to be manipulated into the incision you made. So what will you do?
We can do a myomectomy.
No, this happens commonly, ma. In the clinical scenario, what will you do? Suppose you feel your incision is not sufficient to deliver the uterus out for hysterectomy, a phalangeal incision, what can you do? What will you do to enlarge your incision or your exposure?
We can extend the incision, ma'am.
Extend where? It's a phalange still, no?
Longitude, like T inverted T.
What can I do?
Vertical.
What muscle is there? What hinders in a good exposure?
Rectus abdominis muscle.
So what can I do with the rectus?
Suppose it's difficult. If your abdomen is tight, you're not able to deliver the uterus. What you will do usually?
Cut the muscle.
Yeah.
The muscle and
muscle. So what will you do to the muscle?
What are the 2 kinds of muscle cutting incision you know of? How do you cut the muscle, ma? Rectus muscle?
One is I think in transverse and vertical.
You can't cut the rectus vertically, no. It has to be only transverse.
Transverse. Upper.
Oh,
So
wait.
one, either you can cut the muscle belly itself, or you can go
Attachment.
at the tendinous insertion and cut.
Mm.
There are two different names, isn't it?
Yep.
Yes, ma'am.
What are the names?
So when you cut it at the origin or at the tendinous insertion, what is the name of the incision? It's called Chernies.
Okay.
Okay, when you cut the muscle, you call it as muscle belly.
M for M.
You call it as Maillard.
Maillard.
Maillard incision.
Okay. But in
Okay.
spite of this, if you are not able to see, when you make this kind of transverse incision, what is the thing you have to keep in mind? What precaution you should take? What important structure comes there when you cut the rectus muscle? What is the structure which is there at the lateral end of the rectus muscle in the abdominal wall?
Inferior epigastric muscle.
Yeah, so you have to take care. That should not get injured. If you cut the inferior epigastric, then the patient will develop a post-op wound hematoma. Okay, large hematoma. Any named vessel in the body needs to be ligated. So that holds good for our inferior epigastric also. Otherwise, there'll be a huge hematomas. Okay, now if you are not able to have an adequate exposure in spite of cutting the muscle, what do you do? What do you do in the uterus? A transverse incision, you are not able to deliver the baby.
Inverted.
Inverted?
T-shaped incision.
T-shape. Same thing you do it here also. You make a
Understood.
midline. Okay?
Okay.
Okay, good then. Now you have opened midline. What other problems you encounter in this case particularly?
Additions we can anticipate, ma'am, between the uterine and the
Additions.
anteabdominal.
Okay.
The
so
bladder can be drawn up.
Good. So how do you, approach that? Suppose there's a uterine addition to the abdominal wall. Sharp dissection, and then separate the uterus from the abdominal wall. Okay. Okay. Then what else? What is the other problem you anticipate?
Bladder being drawn up, ma'am, or adherent to the low uterine segment, ma'am.
So how do you approach a drawn up bladder or an adherent bladder during
Ma'am, the UV fold should be opened higher up, ma'am. UV fold should be opened higher up, ma'am, and bladder has to be pushed down. Or if it's a sharp dissection has to be done to release the adhesions, ma'am.
Suppose the adhesions are so dense, you are not able to find your plane. What will you do? How will you separate the bladder from the uterus?
Ma'am, the UV fold, the round ligament has to be open.
So from laterally we can come.
Yeah, okay. Laterally, how do you do it? The bladder is adherent.
The round, from the round ligament, you have to find the plane. And
okay,
then you have to
cut the round ligament. Then how do you proceed further? How will you separate the bladder from the lower uterine segment or that scar?
Sharp dissection can be done.
That is true, ma. Sharp dissection way. What will you cut? Which plane will you enter? There's a technique, na? There's a name for the technique also. Have you heard of lateral window technique?
Yes, ma'am. Yeah, just feel a broad the whole.
What do we do in lateral window technique?
From the avascular, the area we see just below the broad ligament, I mean, in the broad ligament, below the round ligament. And we have to make a hole to it, and we have to.
See, the principle behind this approach is the bladder is adherent to the cervix or the uterus only at the level of the scar. Okay, below the level of the scar, the bladder is free because it's expanding and emptying, expanding and emptying. There are no adhesions in that area. So you try to get into the plane between the cervix and the bladder below the level of adhesion, below the level of the scar where the bladder is adherent. And to approach that area, you come through the lateral side. You don't go in the midline. you come from the round ligament side and you dissect the bladder away from the cervix, the clean wide space or the area above the cervix and the bladder. You open up, hook the scar area, bladder, and then you cut it open. Probably if you, I think you must have seen your professors doing it. Next time when they do, observe that, how they are doing it.
Okay.
So call it as the lateral window technique. Probably
Okay.
if you don't understand after the class, you can just go into the YouTube and then put it and see how it is being done.
Okay.
Okay.
Yes, ma'am.
Can you do this kind of, suppose this patient doesn't have a history of previous to cesarean, can you approach this hysterectomy vaginally?
Non-distant. No.
18 to 20 weeks
We can.
size gravid uterus, ma'am.
So
we
can you
Ma'am,
do
we
it or
can.
not?
We can't, ma'am.
Ma'am, it can be done, ma'am, vaginally.
So it depends on the skill of the surgeon.
Skill of the
Chitra madam
obstetrician.
definitely will
Yeah.
finish it. Chitra madam will finish it.
Revati madam is there.
Revati madam also will finish it. So, what are the contraindications for a vaginal hysterectomy? Anything can be done through the vagina. If we have skill. But then there are some contraindications for the vaginal hysterectomy. What are they?
Presence of additions, ma'am.
Okay. When you suspect dense additions, then
Any bladder addition.
that's what, any addition. Anterior bladder in the case of previous cesarean, posterior additions in the patient with endometriosis and other things. Then what are the other contraindications?
Size.
Pardon? What is needed, ma'am, when you want to do a hysterectomy vaginally? Where do we apply clamps?
The parametrium.
Yeah, in the parametrium. So there should be space, lateral space should be there. If the fibroid is longitudinally elongated, the uterus is longitudinally elongated, you can definitely do the procedure. But on the other hand, if it is expanded horizontally or fills the pelvis and you don't have space by the side, then it becomes difficult. Then where else? And this kind of patients who had previous C-sections.
LSU.
What history? What is the thing you will ask for in their history when they say previous section? And you want to do a vaginal procedure. What is important?
Bladder.
What was the indication for the C-section? You need to know, no?
Yes.
Which case you can't do vaginal hysterectomy? Contracted pelvis. Isn't it?
Yes, ma'am.
And there is no space for the baby to come down. There will be very little space for you to do manipulations also.
Okay. Yes, ma'am.
Isn't it?
Yes, ma'am.
Okay. I'm making you say. So then how else will you do a vaginal procedure? Madam, ninge kelunga, madam.
Yes.
Ma'am.
How will do a vaginal hysterectomy?
Ma'am, network is not.
Small sized uterus, you can do it if the uterus is big like this, 14 weeks, 16 weeks. How will you proceed with the vaginal hysterectomy?
It is a fibroid.
We can enucleate the fibroid, ma'am, before delivering of the uterus because the uterus will be big here in this case. So while going up, we can enucleate the fibroid first and then we can proceed with the hysterectomy.
Or you can dissect the uterus into two.
So we can do bisection of the uterus and
bisection. Okay. Coring. You can do all that and then yes, you can proceed with the hysterectomy. Okay. What complications you expect?
If it's a large, ma'am, if it's a large fibroid, we can expect ureteric injury
In which type of fibroid do you expect ureteric injury?
Broad ligament fibroid or cervical fibroid.
Broad ligament fibroid. Broad ligament fibroid, where will the ureter be?
Ma'am, if it's a true broad ligament fibroid, ma'am, then it will be medial. Ureter will be medial, ma'am.
Ureter
Where
will
if it's
be
a
medial to
fibroid, medial to the fibroid, ma'am. If it's a fall, it will be, I mean, pseudo broad ligament, it will be lateral, ma'am.
To which class this will belong? Figo class.
Type 8.
True broad ligament fibroids will come under type 8, ma'am. Pseudo broad ligament fibroid is nothing but a pedunculated subserous fibroid.
Okay, so you have to, how will you deal with this broad ligament fibroid? You're opening the abdomen, you have seen the fibroid is in the broad ligament, true broad ligament fibroid.
First, we have to identify
what
the
injury what injury you are worried about?
ureteric injury.
Yeah, ureteric injury.
Prophylactic stenting can be done, ma'am.
Prophylactic stenting, if there is no facilities for that.
What else you can do?
What else can
dye
you do?
Dye can be.
No, all
No,
that is
what
not
else you
necessary.
can do?
Dissection.
You have to work, where will you work?
Enucleation inside the capsule, ma'am.
You have to work within the capsule. Okay?
Capsule to prevent the bleeding.
To prevent ureteric injury. Okay. Okay. So this is regarding hysterectomy. Myomectomy, after a myomectomy, what will be the size, ideal size after a myomectomy? Ideal size to be achieved. Any idea? Multiple fibroids you have removed on, so that what will be the future pregnancy rate after a myomectomy?
9, ma'am, 40% will double.
Yes.
If it is a submucous fibroids, myomectomy, the chance of pregnancy is more than 60. It's around 60%, ma'am. Intramural fibroid myomectomy doesn't have much significance effect on pregnancy.
No. What will be overall? What will be the pregnancy rate following a myomectomy? There should be some figures, no?
40 to 60%.
40 to
60%.
Okay. So after myomectomy, large intramural fibroid you have removed. Any other procedure you would like to do along with this? You have removed the myoma, you have closed the myoma bed, etc. You have removed the excess tissue and all. And after that, any other procedure you would like to do along with that?
Two things, right? The effect of fibroid on the pregnancy and the effect of pregnancy on the fibroid. So both you have to explain. So tell what is the effect of pregnancy on the fibroid and the effect of fibroid on the pregnancy.
Effect of fibroid on pregnancy, we have to counsel the patient regarding the complications of fibroid in pregnancy, ma'am. So she can have red degeneration of the fibroid can occur. Then in first trimester, there can be chances of
increase in the size of the fibroid, ma'am. Possibility of the increase in size of fibroid.
Pressure
chances for chances for antepartum hemorrhage can be there. Chances of malpresentation can be there.
Preterm, there's more chance of preterm labor, malpresentation, then
preterm premature rupture
of membranes. Abruption will be more in antepartum, ma'am.
Okay. What is the effect of fibroid on the baby pregnancy?
Ma'am, there can be IUGR, ma'am. IUGR for the baby can also be there because the space will be lesser, ma'am.
So malpresentations increase need for operative delivery.
Section will be more, ma'am.
Okay. Suppose a patient has red degeneration. How will you manage it?
Ma'am, we have to do it. Conservative management alone can be done, ma'am.
Or what will you give?
Ma'am, pain analgesics to reduce the pain we give, ma'am.
Which analgesic? Pregnant, na? Pregnancy and analgesic.
Paracetamol.
Yeah, paracetamol is the preferable one. You don't give the regular NSAIDs.
Yes,
Isn't it? Why?
yes, ma'am.
Why?
Gastritis.
Yeah, that is okay. Gastritis, even a non-pregnant person also, that's an issue. Specifically when it
What
is
is the effect
pregnancy.
of NSAIDs on us?
Prostagland, ma'am,
What will happen to the baby if you give NSAIDs?
premature
Mm.
closure of the-
This is answer.
Yes.
What will happen, ma? Liquor volume?
will reduce, ma'am.
Yeah. Okay. So we specifically try to avoid NSAIDs and we give either paracetamol, or if the pain is too much, you can give the opioids also. SOS. Not too much, but okay. Now and then. Now, she has gone into labor.
Yes.
How will you manage her labor?
They can usually during fibroid they can be we can anticipate PPH, ma'am.
Oh no, first go to PPH directly. Will you allow this patient a vagina? What will be the route of delivery?
Based on the location of the fibroid, ma'am. If it is a huge cervical fibroid, then directly we have to go for a cesarean section, ma'am. And then the patient can go in for like the contractility of the uterus won't be good. Like if there is a intramural fibroid or submucosal fibroid, so they can go in for dysfunctional labor, ma'am.
High rates of cesarean sections are there.
Then
PPH, postpartum hemorrhage will be there, ma'am. You can anticipate postpartum hemorrhage. Post-delivery, you can expect subinvolution and infections.
What else can happen? PPH due to?
Ma'am, the uterus won't be able to contract.
Okay. What else? What about the placenta?
Ma'am, retained placenta will be more. Chance of retained placenta is high.
Okay. What else? Especially when there is a type 3 fibroid or a type 2 fibroid or something like that.
Subinvolution of the uterus, suppose.
What else can happen? Inversion?
Inversion can happen.
Yeah. Okay. So that also has to be kept in mind. Okay. Okay. PPH. How will you manage PPH? Anything different or the same way?
The same way, ma'am.
So what will you do?
Active third stage.
Tell me, ma. Active
Yes,
third stage.
tell it.
Active management of third stage of labor will do, ma'am.
Okay.
So that is symptosin 10 units IM, and then controlled contraction, Brandt-Andrews technique, and then uterine massage, ma'am.
So uterine massage may be a little difficult when you are giving when you are having multiple fibroids. Okay, so that needs to be kept in mind. We have to use more force than the usual stage. That is how it is a little different. Otherwise, it's the same. Okay, now you decided on a C-section. So patient's attender is asking whether the fibroids can be removed. One surgery, na? Problem solved. Will you do it?
If there's if it's a pedunculated fibroid, you can. If it's a subserous pedunculated, you can go ahead with the myomectomy, ma'am. Or if there's any associated torsion along with the myoma, you can go ahead. But sometimes there'll be more chance of hemorrhage will be more, ma'am, during pregnancy in cesarean section, during cesarean section.
So what kind of fibroids you can do a cesarean myomectomy?
Ma'am, subserous fibroid, not pedunculated.
Okay. Then
One is that. Another type. Which type? Where? Depending on the site. There are two schools of thought, no, regarding this.
Yes,
Some
ma'am.
say you can do it. Some
Ma'am,
say
ma'am, the one near the
Ah.
incision, ma'am. Suppose it's in the low uterine segment near the incision. So if suppose sometimes when the incision is been given, ma'am, then it's better to enucleate the fibroid and then to suture the scar, ma'am.
along the line of incision.
Yes, ma'am.
But nowadays they are telling that you can do myomectomy along with the cesarean sections, keeping blood.
Yes, ma'am.
Do you do it, Padma?
Now and then, madam, not exactly all.
Not always. Yes.
Not always.
Mm.
What precautions you take when you do a cesarean myomectomy?
Adequate blood has to be arranged, ma'am, and then we have to take a consent that if suppose there's a possibility that bleeding won't be stopped with all the medical management and the other surgical management, there can be possibility of hysterectomy also. We have to take a consent.
Okay, the consent is fine, but then you are the surgeon. You started doing a cesarean myomectomy. What precautions you take?
Ma'am, it has to be done in during the day, ma'am, so that when that all the senior obstetricians will be available. Then adequate, it should be done in the higher centers, and then adequate blood and blood products has to be available, ma'am.
Okay, that is fine. You are the surgeon and intra-op. What precautions will you do? Will you take?
Reduce blood loss.
Uterine artery, like prophylactic uterine.
Yeah, you're right. What precautions you'll take to reduce the blood loss?
Prophylactic uterine artery ligation can be done to prevent excess bleed.
Yeah, any myomectomy procedure is a bloody one. All the more during C-section when the vascularity is more, isn't it?
Yes, ma'am.
So what precautions you'll take? Apart from the uterine artery, anything else? Suppose the fibroid is in the fundus.
Ma'am, that near the ovarian ligament, even that it can be ligated near the IP ligament, ma'am.
Will ligate or do something else?
No, ma'am, the tourniquet we try, ma'am, near the ovarian, the IP ligament.
So it is a temporary
method. Yes, ma'am.
Okay. Have we reached 7 o'clock?
Yeah, it is 7.
Do we have time?
Chitra, I have done myomectomy in cesarean section when the myoma is in the line of incision. Not much of a blood loss at all.
Okay, ma'am.
We have also done 1 or 2 cases, madam, cesarean myomectomy.
Shall we? Yes.
I think Chitra has to tell the time is up or not. Chitrakala.
Yes, ma'am.
Chitrakala, time is over or can they take a few more minutes?
We can take few more minutes, ma'am. No issues, ma'am.
Okay, you just tell when the time is up. Okay.
10 minutes late,
Okay.
so it's already 7. Probably another 10 minutes we can take, ma'am. Hello.
Yes.
Yes, ma'am.
Okay.
Ma'am, 10 more minutes and we'll wind up, ma'am. Huh?
Yes.
Okay, ma'am.
Okay, what is the other? Suppose the patient is a poor surgical risk. She cannot be taken up for surgery. She recently had, say, a stroke, and she's having a, say, around 20 centimeter fibroid, and she has to be on anticoagulants. Then she's bleeding. The neurology or neurophysician is sending a reference, a gynec reference. How will you manage this patient?
Anything you can do?
Huh?
Anything,
Same, similar
And go
patient.
for non-surgical management, ma'am.
What do you do? In an acute setting and in a non-acute setting. This patient is in the ICU, neuro ICU. They are planning a, for an acute stroke with, if the vessel is blocked and they want to do a thrombolysis. They want to give her anticoagulants and she's having an 18 to 20 weeks fibroid. What do you do to prevent bleeding? It's an acute setting, right?
Yes, ma'am.
And what do you do?
IV estrogen.
Pardon?
No, you can't give, no. It is contraindicated, especially patient is having some neurological problem.
We just discussed now the medical management.
Ulipristal acetate.
No, you have to stop the bleeding.
Tranexamic acid.
Tranexamic acid, they may not like it because they are giving anticoagulants.
Yeah, it is thrombotic actually.
What can you give? You can give a GnRH analog?
Yeah, yes, ma'am.
Isn't it?
Yes, ma'am.
We can give a, and suppose the bleeding is still there from the cavity. Is there anything else you can do? For the fact you have done a hysteroscopic myomectomy and the patient is having a little bleed, what will you do?
Ablation.
Ablation. You have finished the procedure, but then you feel she may bleed a little. What's the, I mean, the other problem is she can develop intrauterine adhesions there. So to prevent all these things, what can you do? You can keep a intrauterine something packing. Intrauterine packing you can do. You can do a intrauterine Foley's placement. Yeah, this you can do. This is in the acute setting. Suppose the patient is a poor risk or the patient doesn't want a surgical management. What are the other non-surgical management for fibroid uterus?
Uterine artery embolization can be done, ma'am. MRA guided high intensity focused ultrasound can be done.
Okay.
Which are the fibroids you will choose for MR focused?
4 to 10
can you do it for all? Huh?
No, ma'am. It should be the fibroid has to be around 4 to 10 centimeter. It has to be big, ma'am. And the distance between the subcutaneous and the fibroid, it has to be less than 12 centimeter, ma'am. And
the patient should have completed the family.
And a perimenopausal age group, ma'am.
Why, what will happen if the patient hasn't completed a family and she comes to you for ultrasound, focus ultrasound, and you do it? What will happen in pregnancy?
Chance of rupture, ma'am.
Rupture is very high.
Sure. Yes.
Okay.
Yes, ma'am.
Then there should not be any bubble in between the fibroid and
it should not be
yes, ma'am. So bubble should not be interposed, and there should not be any scars.
Additional previous scar should not be.
Okay, what are the complications of MR focused ultrasound?
Skin can.
Small minor skin burns can be there, ma'am.
See, I mean, MR focused, how many fibroids do they do the procedure at any time?
It's a very long procedure, ma'am. It requires a lot of time to reduce the size, ma'am. So multiple sittings is required, ma'am.
No, how many they do at a time?
Ma'am, at a time, one only can be focused and done, ma'am. So multiple fibroids will take a lot of time, ma'am. So they prefer single fibroids.
Yes. So when there are multiple fibroids, it becomes too lengthy a treatment procedure. Okay. Then what else can you do? You said embolization, right?
Yes, ma'am. Uterine artery embolization can be done, ma'am.
Okay. So who are the candidates for uterine artery embolization, and what complications you can get after that?
Ma'am, it's usually the one who has completed the family, and
they just want only symptom relief, not willing to undergo a surgery, or who's not.
They're not desiring fertility, and perimenopausal age group it is done, ma'am.
Okay, but before doing that, as an gynecologist, you would like to do something?
Ma'am, you have to rule out any other pelvic pathologies.
Like?
Ma'am, if there's any active infection, you're not supposed to do a uterine artery embolization, ma'am. Or
So
if
you
there's
have to do a clinical examination and rule out any infection. Then second thing.
Ma'am, any ovarian pathology.
More than ovarian pathology in the uterus, what else? She's come to you with an abnormal bleeding, and that's why symptomatic fibroid you are treating.
Malignancy has pregnancy has to be ruled out, ma'am.
Pregnancy has to be ruled out. Malignancy has to be ruled out. You cannot afford to miss a malignancy. So imaging should be pakka, and histopathological confirmation should be there that there is no endometrial pathology, and imaging should not point out that it could be a degenerative change or it could be a sarcomatous change. Yeah, you have to do a proper imaging before you do a uterine artery embolization. Then what else?
The complications can be, the patient can have severe pain, ma'am, post-procedure.
There's something called as post-embolization syndrome, ma'am. 40% of incidents is there, ma'am.
How will you manage it?
Ma'am, conservative management with analgesics and fluid has to be given, ma'am.
Okay. Then what else?
Ma'am, there's sometimes during this embolization, it can lead to premature ovarian failure, ma'am. And they can go into
that comes later. That comes later. As the immediate, what other immediate? Infection.
Infections will be there. Then there'll be discharge will be pain, severe post procedure pain will be very high, ma'am.
Okay.
Then we'll have persistent.
Why the post procedure pain?
Ma'am, ischemic.
The ischemia, ma'am.
Okay. Then what else?
Ma'am, then there is persistent vaginal discharge will be there.
Why? Which kind of fibroids?
In subserosal fibroids, ma'am.
Subserosal?
Sorry, submucosal, ma'am. Sorry, submucosal, ma'am. Sometimes fibroid particles will be excreted will be discharged from the vagina, ma'am. And then then this ovarian, this one will be premature menopause will be there, and ovarian failure will be there, ma'am.
Okay. Sometimes the subserous fibroids or pedunculated fibroids can become parasitic fibroids. They get detached from the uterus and get attached to the surrounding structures.
It is contraindicated
so
in
even, yeah, so that is a problem there. And when somebody is doing a uterine artery embolization, the gynecologist should be prepared to do hysteroscopic procedures also, where the fibroid gets released and gets retained into in the cavity. We have to do a hysteroscopic procedure to remove that. Same way, when the subserous fibroids undergo degeneration and give severe pain, then we have to do laparoscopic procedures and retrieve the fibroids. All these are possibilities. It has happened also. Okay, and then ovarian failure. What percentage of people with uterine artery embolization go for failure?
Failure of the procedure, ma'am.
Pardon?
Ma'am, ovarian failure or failure?
Because of the procedure. Because of the procedure. What percentage?
No.
I'm sorry. Even I don't remember the exact figures. Please go and find out. I can't recall just like that. So what is the difference between the embolization you do for a patient who presents with PPH and for someone with multiple fibroids? What about the future pregnancies?
Ma'am, there will be decrease in rate of fertility after embolization, ma'am. So we have to count, if we're doing it for a PPH, we have to counsel the patients regarding the decrease in fertility rate, ma'am.
No, it doesn't happen. It doesn't happen. See, there's a difference between the two. When they do it for PPH, they usually put large coils into the main vessel of the main uterine artery. Whereas when they do it for fibroids, they use small particles. They go and block the smaller vessels in the fibroid. Okay.
Okay.
So the chance of the patient going for an ovarian failure after a uterine artery embolization for PPH is much less, because they are larger coils. They don't migrate so much. They don't go and block the small vessels of the ovary. Whereas in the fibroid embolization, this can happen.
They'll be small.
Okay. And that is the same reason the patient with a previous history of uterine artery embolization can become pregnant a second time, because collaterals develop.
Okay.
Okay.
Yes, ma'am.
Because in our center, we do quite a few and then they come back pregnant second time. So we have seen a good number of patients who have had uterine artery embolization done for PPH in the previous pregnancies, coming back pregnant next time, and we don't find any increased instance of any, IUGR and other things. They have a smooth next pregnancy. No issues there. So it's a safe procedure. You don't have to do a sterilization following that. It's not unsafe. Okay. Have you read up anything about the genetics of fibroids?
Yeah, ma'am. They say like 40% of cases of fibroids have genetic association.
First degree relatives, they have six-fold increase in the possibility of having a fibroid, ma'am.
So there is chromosomal aberrations, ma'am. There is translocation between chromosome 12 and chromosome 14. Trisomy 12, all these are associated with fibroids.
Ma'am.
Okay, I have to listen to what you said. Good, you have read that up. Fine. Madam Chitra, madam?
Yes. Yeah, 10 minutes over, I think.
Yeah.
Madam, it has been extensively covered. I'm sure the rest of the theory, they can a little bit more, they can go and read up.
Yeah, they can read up from the books.
Yeah, both of them did well.
The practical questions, போய் நிறைய படிக்கணும் அதுமே. But they have done well. Congratulations.
Yeah, they did a good job.
Yeah, congratulations, both of you, for the efforts. Yeah, and good answering.
ரொம்ப hesitate பண்ணாம டக்கு டக்குன்னு answer பண்ணிரணும். You know very well, but don't hesitate. Come out with answers quickly. Okay.
Okay.
Nice.
Thank you, ma'am.
Thanks to Chitra. Thanks to Chitra, Padma, and Anuradha, Kritika, and all. Okay, thank you very much.
Thank you, ma'am. Thank you,
ma'am.
Thank you, ma'am, for giving the opportunity to our PGs to present in this.
Okay.
It was very informative session, ma'am.
Thank you, ma'am, for giving us the opportunity.
Yeah. Thank you, ma'am. Thank you for giving the opportunity. It was nice hearing.
Chitra madam and Padma madam, it was quite a revision for us also. Really, thank you so much. Every PG class is a revision for the teachers also. Thank you so much.
Thank you, ma'am.
Thank you.
Revati madam, thank you.
Thank you. I'm on the way back from Nagarkoil to Madurai.
Okay.
Thank you.
So we wind up, madam.
Okay, bye. Good night.
Bye, ma'am.
Bye, bye.
Thank you, madam. Thank you.
Thank you, Vijay, thank you, bye.
Thank you, madam. Chitrakala, we can log off Chitrakala. Thank you.
Okay, ma'am. Thank you, ma'am.